The next speaker, Dr. Bijoy Chirayath. Sir is an associate professor at Jubilee Vision Medical College and Research Institute, Kerala. Sir's experience and international pain procedures, teaching and training, chronic pain management with focus on back pain and knee pain, ultrasound and fluoroscopic procedures. Sir is published more than 3 international publications and 50 guest lectures all over the India. Welcome you, sir.
Thank you, the organizers. Thank you, Chairman. Thank you for the introduction. This is one interesting topic, more for the surgeon, but unfortunately more so for the anesthetist. How so persistent post-surgical pain is something which no one wants. So I have had suppose we consider 3 different incidences. One of my colleagues, an anesthetist in Calicut, underwent a TKR. She's around 49 years old, underwent a TKR. And 3 days back, she called me after around 2 weeks after her surgery saying she's in severe pain, unable to sleep, gets up at night. So we are wondering what to do. She's been put on NSAIDs with no effect. So we kind of started her on pregabalin, and after maybe a week of sleeplessness, she's at last been able to. She said in the morning she called and said, at last I'm able to sleep well. I've had a patient who's had a radical nephrectomy, and he complains of pain at the scar, and whatever medicine you give him and whatever we try to convince him, we have failed to relieve his pain. So whatever happens, he's not been able to return to his normal active life because even the slight movements cause him pain. Another of a friend of mine, he has had an arthroscopic surgery. All that went well, and during the recovery period, they just kind of yanked off the suction, the catheter, the draining tube. And that has resulted in having chronic pain for years now. Another friend of mine is so scared of needles that he said, give me general anesthesia before you put in a needle. I don't want you to prick a single needle. You anesthetize me and then you do whatever you want. So he's also, so these are kind of things which are happening every day. So I thank ISA, Mysore branch, and this for the opportunity given. So what to know? So when can we call it a post-surgical pain primarily? Are we able to adequately assess it? Is there a preventive strategy, if any? What kind of treatments? Why is it necessary to just offer comfort to these patients? Why is it such a big headache for the surgeons per se? What are the medications we can do? What are the side effects? What are the limitations? And that's it. So, so pain generally that develops after surgical intervention and lasts at least 2 months. So again, that is arbitrary. Other causes of pain have been excluded, in particular pain from a condition preceding the surgery, then we can consider it as post-surgical pain. So this has been 1999, and then, so again we have another definition in 2014 which says that pain has to last for around 3 months post-surgery, and that has to have a different characteristic from the preoperative pain, and it should not be localized to a surgical site or a referred area. Now, so as it is, this is an area which is difficult to study because no one wants to even consider that their surgery has been a sort of failure or that the patient has come back with a worse pain than what initially they underwent surgery for. So again, we have the incidence varies from surgery to surgery, from study to study, and it is actually varying from 11 to 57% following a mastectomy and all that. So as I said, one of the reasons is when do you consider it is primarily as a post-surgical pain, and the other is what is the amount of injury which was involved during that particular surgery? Was it a sort of a mild surgery, or was it an extensive surgery which resulted in that sort of a pain? So what are the risk factors? So being a woman, young adult with the genetic predisposition and psychosocial factors are some of the patient factors. Pre-existing pain, sensitivity to pain, and painful conditions in other parts of the body may cause central sensitization leading to chronic pain. And perioperative factors like the length of surgery, extent of nerve damage, all those things. So there is a recent study has demonstrated that severity of pain in chronic post-surgical pain is correlated with an mRNA expression of the signal transduction genes, representing a genetic influence also. So now we'll come to the anesthetic part. Now suppose we say that, is there a way to prevent it? So we know, for those of you who use ultrasound, we know that most often a nerve accompanies a vessel. While it is easy to cauterize a nerve, if you end up cauterizing a nerve instead, you could end up with a chronic severe neuralgia. So is there the extent of tissue damage done by the surgeon? So again, a rash surgery, a hasty surgery could result probably in more nerves which are damaged, more nerve twigs which are damaged, and that can lead to pain. Again, suppose we think, okay, that is fine, so that is what we think. Then what happens with minimally invasive surgery? So while we would like to think that minimally invasive surgery will not cause this sort of pain, but unfortunately, that has not always been positive. So again, suppose you look at sternotomy versus a thoracotomy. A sternotomy is less likely to cause post-surgical pain compared to a thoracotomy. So these kind of variations, while they are easy to say, they are even the simplest of surgeries can result in severe, unbearable neuropathic neuralgia, which is unexplained by the extent of the surgery. So treatment of pre-operation. So one of the main reasons why they say is that, suppose is it because we have caused a central sensitization by not treating patients who have undergone surgery adequately, so with pain. So post-operative, so you're given a regional anesthesia. We have done a recent small study for an audit purpose, and what we found is that after spinal we have forgotten about everything, and immediately as the spinal wears off, there is a surge in pain, a hyperalgesia among almost all the patients who undergo a hyperalgesia, and so that we are not taking care of as anesthesiologists. So the post-operative component is very often missing in busy practices, and is that causing a central sensitization which leads on to something which is unbearable for the patient. So again, while we say that there is a positive effect of regional anesthesia, recently even Tata Memorial Hospital has come out with an extensive study which says that infiltrating local around a breast tumor will reduce the recurrence of the breast cancer itself. So regional anesthesia, all those things, so following laparotomy, cesarean sections, so etc. So all these things, regional anesthesia is supposed to have helped us reduce pain, but unfortunately, these results are also not consistent enough. That is the thing. So, that is where the risk of surgery lies. If you do a surgery and it does more harm than good, then especially in a major surgery like TKR and all that, what is our role and what scientific evidence can we put on the plate to show that we can prevent all this? That is a challenging question for all of us. So again, so primarily what we can do is, what we can do to reduce is try to use regional techniques, use a protocol-based post-operative analgesia regimen. Make sure your technician goes around, or your PG goes around for post-operative rounds, calls you up and tells you that these are the patients who are in pain and what can be done to reduce the pain. Have a post-operative assessment of these patients so that we don't cause central sensitization and reduce the quality of life of these precious patients. So multimodal. So again, now I have given you an introduction. Now how do we go about treating this pain? So I wouldn't want to go into a medication directly. Why would that be? Every medicine, however simple, however complicated, has its side effects. Suppose I were to tell you, okay, pregabalin causes hair fall. Not that I have too much left. Then we will, pain is okay. Forget about the pain. I don't want my hair to fall. So suppose we were to say that you're going to wake up in the morning unable to move after a few doses of pregabalin. But it's going to take some time. Then you say, no, I have to go to work at 4 o'clock. That drug is not available to me. Okay, suppose we take something as simple as paracetamol. So suppose I say that paracetamol is going to make you brave. Would you agree with me? Suppose I say I had 4 pegs of whiskey yesterday night. I'm standing here before you and I'm going to give a spinal anesthesia and I'm not getting it and I'm just going to prick it. And instead of the 4 pegs of alcohol I had yesterday, just to liven it up, I woke up in the morning with a severe headache and I took 2 paracetamols. 650, full of paracetamol actually. So is the alcohol responsible for my pricking this action, or is paracetamol responsible for it? Suppose I were to say it is paracetamol, how many of you would agree with me? So they did a simple study where they gave a particular dose of paracetamol to a group of people. I have 3 minutes, sorry, I'll just run up. So they gave a group of drug of paracetamol to a group, and to another group they just gave a placebo and asked them to blow balloons. So they said that the people who were blowing balloons with paracetamol simply did not know when to stop. So the risk perception had come down in people who were taking something as simple as paracetamol. Forget about the rest. So I've got 2 minutes. Anyway, so we have gabapentin and pregabalin, and generally, as most of these chronic pains have the neuropathic component in it, so you have to actually include them in that, and pregabalin is generally better than gabapentin per se. So generally we start from a low dose, 50, or you can start from a higher dose and bring it down. Antidepressants, SSRIs can be used, and actually venlafaxine has been proven to be much better than fluoxetine or most of the other antidepressants in the treatment of chronic CPSP. So again, another wonderful fact here. See, suppose I were to give a low dose ketamine for all my general anesthesia patients. Is ketamine the wonder drug? So you have what, dissociative anesthesia there. So instead of, along with propofol, should we be giving a low dose of ketamine for all our patients? Because as they say in some of these studies, there is no difference in your hallucinations, nightmares or anything, and a considerable reduction in your pain scores, and as ketamine has a wonderful analgesic effect, that is an option for as an NMDA antagonist in the treatment of especially patients who you think are already very sensitive to pain and can develop a chronic pain syndrome. Should we be giving ketamine for all these patients? So clonidine, local anesthetic, lidocaine can, as it is improve, and NSAIDs and paracetamol have no evidence in the prevention of or treatment of actually this sort of pain. So, steroids, doubtful. Opioids, once you stop opioids, it will lead to a hyperalgesia, and again that pain can occur. So most of the other things are, there are limited evidence to prove that these studies can work. And see, in some people you tell them that this is a scar neuralgia. So many surgeons send the patients to me, they have not even examined the patient. They have not, it's just the scar which is causing the pain. You just relax, enjoy life. They will accept it. Or you give a local injection there, they will accept it. So at least do a proper examination before we decide that even a scar neuralgia can be treated by just comforting these patients most often. So management has, you have to do into all the neuropathic and the nociceptive pain. And as I said, you can do numerous interventions, including nerve blocks, and it's a tough topic to finish in 15 minutes. And in the surgical management, you can excise the neuroma, insert it into the latissimus dorsi, for example, or the ilioinguinal iliohypogastric. You can do a surgical, which is the last of last resorts. Lifestyle modifications always a must, and psychological investigation. What is the difference between a CBT and an operant conditioning? An operant conditioning is one form of psychology where only the change in behavior is advised. The focus is always on behavior. What you think and what your imaginations, fantasies are not important. Only the focus in operant conditioning is in your behavior, while CBT will give some importance to your emotional quotient also. So as it is, it's horrendous to come with little pain, and most surgeons don't know how to deal with it. So be able to comfort these patients. We have discussed some of the risk factors, preventive measures, extensive surgery, and the management, what are the drugs which are possible. I've exceeded a minute. Thank you for this opportunity once more. I am from Jubilee, and thank you everyone.